Hello. ما خش.
أنا أرسلت لك اللينك.
هيثم هو ده اللي هناك بذاته. تضرب إليها
أيوة.
كيف؟
الكاميرا واضحة الصوت.
الكاميرا واضحة؟ أنت شايفيني؟ أنا ما شايف. لا ده أيوة كده تمام. تمام؟ ألو؟ السلام عليكم. معانا؟ ما في زول؟
يا دكتور.
السلام عليكم.
عليكم السلام.
باتش كم وكم المعانا هنا
25.
25 كويس. في غير 25 في؟
ما أظن.
ما أظن. خلاص طيب. بسم الله الرحمن الرحيم. Welcome to this lecture on infectious and tropical diseases which we have started some weeks ago. And today's lecture is about schistosomiasis. This is the second lecture on schistosomiasis, such an important disease, which second only to malaria in the importance of tropical diseases with morbidity, even more than malaria, but with limited mortality. Malaria is a disease of mortality, but here schistosomiasis, although it can kill, but it is a disease of chronic illness and devastating effect on the health of many individuals. Remember, we said more than 200, maybe 260 million are infected with schistosomiasis worldwide. 90% of them are in Africa, and those who are at risk of getting schistosomiasis from the recent dams and canals and agricultural area is more than 600. So it is an important disease, although we thank God that there is a lot of progress in the treatment and control of this disease. We note with happiness that some countries in North Africa and even Egypt, the mother and the ancient history of schistosomiasis, where has been. Now it is almost controlled to a level below what can worry the health system. So, and the major advances in which led to this is the discovery of praziquantel, which is the only licensed drug, safe, orally given, which treats individual patients and can be used as preventive chemotherapy. Preventive chemotherapy is mass chemotherapy for disease with in an endemic region. So let us just send you some telegrams about schistosomiasis. We can go through it. It's a trematode, blood fluke, which lives in the blood system, in the mesenteric capillaries and venules, in the hematobium, and in the mesenteric, which is the inferior mesenteric venules over the colon. Japonicum is something which in Southeast Asia. This is a heavy infection type of schistosomes, and it involves not only the colon like Mansoни, but also the colon and the small intestine. So the pathology is caused essentially and almost exclusively by the eggs. So the other sperm, which lives in the blood venules, coating itself with the human antigen so that it cannot be attacked by antibodies, does not cause a lot of pathology, actually very minimal pathology, ectopic here and there, but the main pathology is the eggs. Obviously, it is a disease which needs canals and snails, intermediate hosts, where the asexual part develops within the snail, and the sexual part develops within the human, where the male carries the female, copulating and producing thousands of eggs per day. The lifespan of the worm is 7 years, so it remains within the body. Just imagine excreting one pair, excreting 1,000 eggs a day for 7 years. That is very heavy. And it's been noted that the eggs pierces through the bladder wall, and 50% of this amount of eggs goes in the urine, and in the 6 months on 50% also of the eggs pierces the colon, mainly rectum and sigmoid, and then it goes in, 50% goes in the stools. So if you have thousands of eggs, then 1,000 maybe reach the water canal in massive to infect the snails and produce cercaria, which is the infective form of schistosomiasis. It is important to note that we have the hematobium, T, terminal hematuria, and it is terminal hematuria painless, and it is a terminal spine. So T is a terminal spine, terminal hematuria, and hematobium. Okay, Mansonia is the intestinal form, which causes a lot of harm as well. Both species causes a lot of harm. So it's the essential pathology is granuloma. If you have an egg in the middle, then granuloma forms, which are mononuclear cells, plasma cells, eosinophils, and fibroblasts. The periphery is usually the plasma cells and lymphocytes. The inside is the eosinophils and so on. The fibroblasts will produce collagen, and the collagen goes out to be hardened to cause fibrous tissue in wherever it is located. And here, what really matters to clinicians is the deposition of eggs in the periportal tract of the liver, leading to fibrosis along the portal system. So it's important. Okay, and so what remains to us is, detailing the clinical features of each disease, the complications, and the diagnosis and treatment. So if you bear with me, we'll go through it. If we talk about schistosoma hematobium, as we said, it is a disease of the bladder. The ureters may be affected secondary to the bladder. Eggs may be deposited in the ureter, but not a major problem, but mainly in the bladder. And in the bladder, we don't say it's only pathology, But since it is now very clear that this hematobium affects the genital system, so we say that eggs are deposited in the pelvis, both bladder and genital system. And in a matter of fact, now as people became more aware of the complications of hematobium in the genital system, now there is a big chapter about the genital schistosomiasis due to schistosoma hematobium, and we will come to that. And this is what raised the interest more and more in schistosomiasis because of the gender issue, because of the women, and because of a disease which is being neglected, not being treated from the genital point of view. So if you take the part of the bladder, the eggs find their way from the worm through the wall of the urinary bladder. Okay, the eggs produces lytic substances which facilitate piercing through the vesical wall, and there, what happens is some of them they will get out, causing ulceration and because of bleeding, or some of them are trapped in the submucosa. Okay, 50% of them will remain in the body, 50% will be out, and those eggs which remain in the body can be carried further distally to other parts of the body, causing granuloma, and depending on where they lodge, they can cause symptoms. So coming back to the bladder can cause ulceration, and if you look through cystoscopes, you can see either ulcerations, sessile polyps, or even pedunculated polyps, and calcification. And there is sandy patches. You read about sandy patches. What are sandy patches? Sandy patches, the area is irregular, folding, yellowish, brownish structure, and surrounded by fibrous tissue or fibrosis. So this is what you call sandy patches, and then you can get actual calcification in the bladder. The ureter can be affected in two ways. One is you have the ureterovesical orifice, and if there is granuloma there, the granuloma can obstruct the flow of urine, or it goes into fibrosis when it is occluded by fibrous tissue. As I said, eggs may deposit in the ureter and cause fibrosis and narrowing. The end result is you get obstructive uropathy because of the obstruction at the ureteric orifice, ballooning of the kidneys, and hydronephrosis with damage to the kidneys, and then end result renal failure. So it is hydroureter, hydronephrosis, vesicoureteric granuloma and fibrosis, and you may even get fibrosis and loss of sphincter, which will give you reflux of the urine back into the urine, giving back into the kidney, giving you infection or pyelonephritis. The importance of hematobium is the development of squamous cell carcinoma. It is a precancerous. This is for sure, and there are a lot of evidence from that. It's been reported in Egypt more than any other country. This carcinoma is a squamous cell carcinoma. The usual carcinoma of the bladder is the transitional cell carcinoma. So this is different. It is due to metaplasia of the cells due to irritation by schistosomiasis. Number two, it is more in males than females, and at a young age group. So this is particularly a cancer which is secondary to a parasitic infection of schistosomiasis. When we come to the genital part or the pelvic part, it is very important. End result may lead to infertility, ectopic pregnancy, and a lot of symptoms. The first symptom is you feel pain in the pelvis, you get dyspareunia, which is pain on sexual intercourse, pain to the female, blood after coitus. So these are the symptoms which will come. So what happens in the genital? Okay, eggs are deposited in the vulva, maybe outside, maybe in the vagina, and maybe in the cervix, and rarely in the uterus and the tubes. This is in female. Okay, what happens? In the cervix, you can see ulcers, you can see nodular structure, which easy bleeding, and this is why you get blood after coitus. So this is, you can get polyps, and some of these picture may be confused with carcinoma of the cervix. So it is important. The position of eggs in the tubes may damage the tube, leading to ectopic pregnancy, leading to infertility. So it is a disease which has to be considered. Luckily, if you catch the patient early with anti-schistosomal drugs, then this can be reversed to a large extent and save the women from being infertile. In men, likewise, you just put the pathology, put the anatomy, and then put the pathology, and you see the symptoms. It can deposit in the testis, giving you orchitis and epididymitis in the epididymis, okay, and then it is construction of the or obstruction to the canals, lead of the semen to the ejaculation. All this will be disturbed, and it is reported that one huge testicles, which was thought to be seminoma, has been removed. But then after that, it was discovered to be only schistosomiasis. So it's important to consider schistosomiasis in endemic areas where you can see odd masses, which which will be diagnosed later as just the granuloma and the changes associated with schistosomiasis. So it is important to bear it in mind wherever there is an endemic area. So it is now it is very proven that genital schistosomiasis predisposes 4 to 5 times to HIV. So these ladies not only are prone to infertility, dyspareunia, salpingitis, and tubal obstruction, ectopic pregnancy, but also to the infection with HIV, which is 4 to 5 times. In males, it is important to, one of the symptoms which worries males is hemospermia. That when ejaculation comes, or when ejaculated the semen, it contains blood, what is called hemospermia. So this is another feature which it can come. But unfortunately, many in the endemic areas are not very sensitive to symptoms. Maybe that because of the immunity, these symptoms are modified. Maybe they are used to it. Maybe it is something which they don't note, or culturally they cannot. But these are symptoms. Even the hematuria, I told you last time that hematuria in young people, like 10 years, people think this is partial puberty, reaching puberty, analogous to the menstruation in girls. And so this is culture. You need a lot of health education in that region. So this is genitourinary schistosomiasis. It is due to schistosoma hematobium. There is excretion of eggs. The spine is terminal, and it is responsive to praziquantel if caught early. The pelvic part is now gaining momentum in the importance. When we talk about Mansoni, because I'm not going to bother you a lot with Japonicum, which is a heavy infection, and the ova is different. But let us concentrate on what worries us in Sudan is S. mansoni. S. mansoni. And this is colonic. It is colonic infection because the worms live around the mesenteric and it prefers the inferior mesenteric plexus, and then it does what it does as far as colonic symptoms are concerned, and as far as peripheral effect of the liver. Okay, what does it do in the colon? The colon, it's mainly due to the penetration of the eggs in the lumen. It may be trapped in the submucosa, giving you the following: ulceration, may be seen polyps, may be seen sessile polyps or pedunculated polyps. And this can easily be seen by sigmoidoscopy. And in some of these polyps, when they are multiple, they simulate the inherited polyposis coli, okay, which is an inherited condition and it's a precancerous. And again, all the stories that colon has been removed because it is thought it is polyposis coli, while it is schistosomiasis. These polyps, if you take a biopsy from them, they have a heavy load of eggs. These are the trapped eggs which will cause the polyposis. The symptoms of schistosoma mansoni remind you that in endemic areas, it is by and large asymptomatic. And this is the worry. It's asymptomatic. And why is it asymptomatic? Maybe that there is immune modulation and the body accepted the eggs around, or it is some suboptimal education levels that people are not searching their body very well in areas where, if you have just a patch of redness, you think it's blood coming out of you, you run to the doctor, and then you get treatment when it becomes nothing. But here it may be that the level of education need to be raised. That is number one. But the fact remains that these patients are asymptomatic. What is the importance of this information? Number one, when you use mass chemotherapy, preventive chemotherapy, people may not be enthusiastic about taking the drugs because they don't have symptoms, although they do have the disease. So this is number one. Number two, it is the symptomatology. When they have the infection and they don't come to the hospital, then this will lead to the gate of complication. So, and in Jazeera, extensive studies which has led to the fact that people with periportal fibrosis, this is an advanced stage of schistosomiasis leading to varices. This has been, many patients, and there is papers which I will give you now, have told us that the patients never remember they had schistosomiasis, and they present only when they have the hematemesis. So it's so it can cause blood in feces, blood diarrhea. It can cause tenesmus. It can cause precipitancy. It can cause, symptoms like bacillary dysentery, urge to defecate, diarrhea and blood, and these are some of the symptoms. Maybe occasionally comes and goes, but it is something which is noted. Nowadays, we talk more about subtle symptomatology or subtle clinical features of schistosomiasis. And these are because it is a disease of children. It starts from 5 to 15 or 5 to 17. The children are noted to be stunted growth, number one. They are anemic and they do less in schools. The cognitive function is impaired. So this is what we call subtle clinical features of schistosomiasis. Why do we think that these are important? Because in areas of controlled studies, they have shown that if you give praziquantel to the children and follow them up, their weight improves, their anemia subsides, and they perform better in school, the cognitive function. So these are some of the things which you should note. I mean, we are being carried for a long time by symptoms like blood, like diarrhea, and so on and so forth. But these are indirect effects of the disease. Why do they get anemia? Maybe because of blood loss. It's iron. But another problem is that they get lodged iron, which is not being used, or chronic infection may lead to chronic normochromic normocytic anemia. So anemia is a fact, and these are what we can observe from the symptoms of schistosomiasis when it's in the acute phase. Please differentiate between two acute phases. The acute phase, which is not common in our countries, endemic countries, this is Katayama reaction, okay? And then the acute phase is the one which I have been describing. And there is a late phase, which is complication. So when we talk about diarrhea, blood in the tenesmus, and so on and so forth, this is acute schistosomiasis or subacute schistosomiasis, ending to liver fibrosis, And there are many terminologies for liver fibrosis called hepatosplenic stage or chronic stage or the liver stage. But this, what we describe, is what we see normally in schistosomiasis. Okay, what I would like to emphasize here is the late stage, okay, because the late stage is in a way is a failure for the medical system. It's a failure on the patient's side. It's a failure on those who are preventing schistosomiasis. You should never allow the patients to reach the hepatosplenic age or type of disease. So what happens in hepatosplenic? Because Katayama reaction, which is an acute reaction, I don't want to impose it on you or put it right now, till we finish from the important ones, because it's not all that common, may be common in expatriates, visitors, but to us it's not a big issue. Okay, the distal or ectopic eggs go everywhere in the body, everywhere, from the skin to brain to spinal cord to lungs, everywhere. So it is what we call ectopic eggs. All right, we have two things. One, ectopic eggs, all right, causing granuloma and then causing fibrosis, as we said. And then we have lumps of eggs, which will cause bilharzioma. So the eggs, when they are in collection, they call bilharzioma and they look like a mass. But the common thing is the eggs, single eggs or double eggs, which will go and cause granuloma and then ending with fibrosis. According to the portal tract, the eggs which are loose from the inferior mesenteric radicals go up to the portal system or to the main portal tract system. And they end there in the periportal area, the pre-sinusoidal periportal area. And when they deposit there, they invite granuloma. And if you take a biopsy of that area, you get an egg in the middle, and then a lot of cellular infiltrate around it, okay, and some fibrous tissue. As we said, the macrophages, the eosinophils, fibroblasts, plasma cells, all these end with fibrous tissue and fibrosis. What will happen is the radicals of the portal system is strangulated, okay? They get narrowed because of the fibrous tissue and they get blocked. If you get radicals of the liver, and these are the far radicals of the liver away from the portal hepatis, they come back as a back pressure leading to portal hypertension. Portal hypertension, okay? The portal hypertension is a syndrome which can occur with periportal fibrosis, and it can occur with other pathology. Mainly, you can have thrombosis of the portal tract or portal vein, like in simple, if you have a trauma to the upper abdomen, you can have a thrombosis, okay, of the portal system, of the portal tract, and that will lead to portal hypertension. But here, the portal hypertension is secondary to the occlusion of the peripheral portal radicals, okay, due to fibrosis. And this fibrosis, if it is complete, you can see it like a stem, clay pipe stem. Clay pipe, I send you some pictures of the liver, and it shows a streak of whitish or brownish area like that, which is like a clay stem of the pipe al-ghulun. You take the part which is where you put the tobacco, and the rest is the stem. If you put stems in the liver like that, it will give you the picture of periportal fibrosis. The description is important, and there are very good pictures from Sudan about periportal fibrosis from Professor Ahmed Mohamed Al-Hassan, who did a lot of postmortems in Sudan, and he described this periportal fibrosis very, very well. That pathology, seeing it in pathology and real postmortem, this has helped us later on to look by ultrasound to diagnose these periportal fibrosis. And I think one of the major development in our understanding and control and doing well with schistosomiasis is two things. Number one is the ultrasound in diagnosis of periportal fibrosis, because then we were able to assess morbidity, not only in the hospital, but in the field. Number two, assess treatment. And the other major development is the development of praziquantel. So these two are the major advances in schistosomiasis. So back to the liver. Once you get periportal fibrosis, then infection more eggs are being deposited. And once more eggs are being deposited, then what will happen is more fibrosis. The liver will shrink down because the fibrosis area will be increased at the expense of the hepatocyte. And then portal hypertension will increase. One important fact is it's a dynamic problem. It's a portal hypertension. It's a dynamic problem. It's not a hepatocellular problem. So the hepatocytes within these brands or bands of fibrosis, the cells within are clear or healthy. So it is not cirrhosis. It's not cirrhosis, periportal fibrosis. And cirrhosis, if you remember, the definition of cirrhosis is it is death of hepatocytes and regeneration. And this is total in the whole body. If it is due to alcoholism, hepatitis B or C, okay, or hemochromatosis, you find all the cells being affected, and it is not limited to any portal area or any part of the whole area. So it is not cirrhosis. Periportal fibrosis is not cirrhosis. Cells in between are healthy. This is why in early stages of periportal fibrosis, serum albumin is normal, prothrombin is normal, because these are the two parameters of metabolic function of the liver, prothrombin and albumin. These are normal. Okay, enzymes are normal. Okay, but the portal pressure is very high. It's very high due to obstruction. I hope I have then made this very clear, because then a lot of what we are going to say is dependent on this factor. Okay, so what happens with the high portal pressure? Number one is you have a cushion in the spleen. Once the portal pressure goes high, it goes back, it rests on the spleen. And what happens is the spleen will be enlarged. Please differentiate between two splenic enlargements in schistosomiasis. Early on, what I said, not the Katayama, but early on, even in Katayama, you get enlargement of the spleen and enlargement of the liver, as well as the diarrhea and whatever. Okay, but here the spleen is different. It's different. There you have an enlarged spleen, an enlarged liver, but once you give treatment, the spleen goes back to normal, the liver goes back to normal. Here, it is permanent. It is an end stage. And the spleen here becomes not the soft spleen of the early infection. It is firm, it is very large. It can cross the umbilicus to the iliac fossa. And the liver here becomes firm, if it is enlarged, it's firm. Or if the fibrous tissue expands in the liver, it becomes shrunken. So it is the main effect. What we are going to talk about is the increase in the portal pressure. What happens? Number one, splenic enlargement. Okay. Number two, because of the high pressure in the portal system, the system would like to open channels to relieve itself. And these channels are the hidden or occluded portosystemic vessels. And they open up in the umbilical cord, because the umbilical was delivers the blood from the placenta to the left portal tract, left portal branch, and it gets occluded after delivery. But when you have high pressure, then this vessel reopens and leads to blood going to the skin, what we call caput medusae, is the vessels around the umbilicus. Okay, the other area of opening is in the lower esophagus and cardia of the stomach, and the cardia. And these are varices of the lower esophagus and cardia, okay, because they give relief. And thirdly, not too much, is hemorrhoidal plexus. It also opens up, and it is also recognized that in portal hypertension, you can get hemorrhoids from the increased portal pressure. So this is the consequences of the increased portal pressure. And in treatment later on, surgeons will try to relieve the portal pressure through pouring the blood into the systemic channels, because the systemic system or the systemic venous system is more accommodating. It's a bigger space-wise, not like the portal pressure, which is very limited between the spleen and the liver and the mesentery. So later on, people are trying to use this relief into the systemic plexus rather than relieving it from the portal tract. Okay, so this is what happens. And the liver may be enlarged early on, but it can be shrunken, and it can be irregular, and it can be firm. Okay, what about ascites? Ascites can occur in portal hypertension, but it is not as clear as in cirrhosis of the liver. In cirrhosis of the liver, because of the low albumin and because of the portal hypertension, ascites is located in the peritoneal cavity. Okay, so the portal hypertension is localized ascites rather than cause ascites. So you could ask, why are patients with portal hypertension often in the photographs are being photographed with ascites. Two reasons. One, there is what we call end-stage periportal fibrosis. That is to say, what is left out of the hepatocyte because of the encroaching fibrosis is becoming less. So it is less like a occupying lesion. Okay, less cells are now healthy because the cells has been eaten out or been replaced by fibrous tissue. And this will give you a picture very much like cirrhosis. The second point is you may have infection with B or C or E viral hepatitis, B, C, or E, and this will lead to hepatitis and cirrhosis of the liver. So you may have an coexistent cirrhosis with the periportal fibrosis. But the end result is this is a stage which is very, very dangerous, and people die from schistosomiasis mainly because of variceal bleeding. Unfortunately, the varices of schistosomiasis is very huge, okay, tortuous, and when they open, you can lose the patient, and you can lead to loss of massive amount of blood. Okay, in the hematobium side, apart from the morbidity, death can occur from the metaplasia and the carcinoma, squamous cell carcinoma of the bladder. Okay, the periportal fibrosis is essential. I will come to the treatment of that, but would like to cover some of the what we call ectopic or exotic presentation with schistosomiasis. Number one is salmonellosis. Salmonellosis. It is now very evident from research that Salmonella typhi or Salmonella paratyphi inhabits the gut of schistosomes. Inhabit the gut of schistosomes. Okay, and they regurgitate the bacteria into the bloodstream, causing septicemia or bacteremia of Salmonella. So the patient will become ill, febrile, fatigue, loss of weight, vomiting, okay, in a similar way to Salmonella typhoid fever, okay, and this is a chronic schistosalmonellosis, and you need here to cover both Salmonella and the treatment of schistosomiasis. So if you kill the schistosomiasis, you also help to kill Salmonella, and Salmonella obviously is treated by certain drugs. You used to use chloramphenicol, but now even Septrin or cotrimoxazole can be very useful. So that is one syndrome, which is called schistosalmonellosis. Number two is ectopic eggs in spinal cord, leading to paraparesis or paraplegia, and into the brain, causing space-occupying lesion. Luckily, it is not with Mansonia as often as with Japonicum. With Japonicum, there is a lot of granuloma, maybe shot in the brain and giving you epilepsy. Once you have a space-occupying lesion in the brain, one of the responses of the brain is headache, blurring of vision because of papilledema, and seizure, irritation of the. These are the symptoms of a space-occupying lesion. Symptoms of paraparesis or paraplegia is due to some granuloma around there. But it is being reported that adult worm can dislodge themselves and go to the spinal cord. So not only the eggs is the granuloma, but it's been reported that some of the worms, why do they lodge themselves from the venules up there? It is not very clear, but it can happen. It can happen that these are some of the complications of schistosomiasis. One further complications is pulmonary hypertension. Pulmonary hypertension. Pulmonary hypertension occurs with Mansouri more than with hematuria. And this is due to the X, which goes to the portal tract, but they don't settle in the periportal tract. They pass into the hepatic veins, into the inferior vena cava, and settle within the pulmonary arterioles. And they cause endoarthritis. They block the endoarthritis, leading to pulmonary hypertension. Again, luckily, it is not very common. It's not very common, but you can cascade it. You can take it to other symptoms. If you have pulmonary hypertension, then you have a strained right ventricle, then you have palpitations, maybe, then you may have failure of the right ventricle due to heart failure. And this, there are certain pictures, certain areas, certain X-rays or certain radiological findings in this case of pulmonary hypertension. Okay, as what we would like now to put to the table is the diagnosis and the aims of management. The aims of management. What do we aim with the management? But diagnosis is being done at two levels: level of a patient who comes to you maybe with symptoms, and you need to treat the symptoms like any physician. Okay, and then because the treatment is not 100%, then you have to follow the patient up because he still have some residue of worms which need to be treated. So that's as far as a patient who comes out of an endemic area, because we aim at cure. Cure meaning no worm is left behind. Okay, if he is living in an area where there is schistosomiasis, reinfection is very common. And if reinfection is very common, we aim at reducing the number of worms. How do we reduce it? We reduce it by praziquantel, and the indication of reduction of worms is the reduction in what we call egg load. The egg load. We count the eggs in a milligram of feces, and we can say, well, this patient is producing 1,000, 5,000 eggs per milligram of feces. If you put out 1.5 kilo of feces every day, which is the normal physiological, then you can count how many number of eggs that can be excreted to get into the water to feed the snails for more development. So in patients endemic, we aim to reduce the morbidity, because if you reduce the number of worms, you reduce the number of eggs, and then you reduce the morbidity from schistosomiasis. So the treatment there has multiple objectives in the field. Number one is we reduce per individual the morbidity as much as we can. Number two, we reduce the output of eggs in the canals, all right, and this will reduce the number of snails which are infected and the infection rate, because this is interruption of transmission in a way or another. Three, it will hold on any future complication of schistosomiasis, like the liver periportal fibrosis. So it is. These are the objectives of treatment. All right, and now we are talking more and more about mass chemotherapy. Mass chemotherapy giving everybody. And as I said earlier, many patients in the field are asymptomatic. So if we can get a proxy of what is the endemicity of that area, and if it is high enough, like 40%, then we treat everybody, because If you just ask them, or if you investigate the stools, it may be negative, while the patient still have the schistosomiasis. So it's that is important. We go from hospital to the field to reduce the morbidity and mortality. Okay, the diagnosis, the golden measure is presence of X, either in the urine or stools. And we have different ways of detecting X in the urine and detecting X in the stools. The urine is a thermal hematuria itself is an indication of, in an endemic area, is an indication of schistosomiasis. So if you want a proxy indication of presence of hematobium, you just go to school and ask who passes red urine, and this is an indication. If you want it more precisely, you can ask each patient to give you the last drops of his urine, each student to give you the last drops of his urine and get a stick, hemostick, and then see if there is occult or obvious obvious blood. And this is an indication. If you have 40 out of 100, then the prevalence is 40%. And the population we go to is the schools. You remember, I told you that this is a disease of children between 5 to 17, maximally at 10 or 11. Okay, these are the high prevalence, number one. Number two, the highest excretor of X. Okay, what we call prevalence and intensity. Intensity is the quantity of X per gram of feces. This is intensity. Prevalence is even one, excreting one egg is positive, then this is prevalence. So it is disease of children, but complication appears 15 to 20 years later because they peak at 35. So if we wanted to study the prevalence of or the intensity of schistosomiasis in a community, we go to schools. We go to schools because almost 65% of patients in an endemic areas are children. So this is good because once I go to school, I treat almost 65% of the worm load in a community. Not only that, but because of children cannot be controlled, they go and swim the canals, they are not very well controlled. What's the say that again? أحمد ما سامع. ما سمعت حاجة. Hello? Hello? Anyone there to say yes?
Yes, doctor.
Yes,
We're
sir.
there.
Did Ahmed, did he ask a question? روبا
لا بالغلط شكله.
بالغلط yeah. Anyway, so the children, luckily that we can have school children who are, in the schools. So it's very easy to go to. Logistically, it's very easy. Two, they are within our regulation. We can observe them. They can come for follow-up and so on. So being a disease of children is something which is a blessing. And the complication comes later. So the effect of treatment has to be judged from either an individual who have left the endemic area, and in this one, we need to have 100% cure, even if we give treatment 3-4 times. Okay. Number two, those who have an endemic area, we aim at reducing morbidity so much that it doesn't come to harm the patient, so much that it will reduce the transmission by reducing the egg load and egg excretion in the urine and stools. Okay, The diagnosis, as I said, the golden is presence of X. So in urine, tips to get maximum, number one is the end of urine. Two, in midday, you go to midday collection. Three, you can get urine and do sedimentation, sediment the urine and look into the microscope. Okay, you see the X in hematobium terminal. Another method of detecting a viable X, using the word viable X, is you put the sediment in warm water and with light shine on the glass, and then this will hatch, the eggs will hatch, and Merycidia can come out. Merycidia is the embryo, which is ciliated. It has a small hair-like, ciliated, and it swims. You can even see it with naked eye. This will tell you straight away, not only the diagnosis is positive, but there is active infection and viable eggs. This is Merycidium, or what is called hatching test. Okay, in stools, it can be done. Okay, light smear, or you can do a heavy smear, what you call K2-CATS. K2 and CATS are two scientists, Brazilian scientists, who devised a method of taking a lump of stool and stretching them in cellophane, and then count the number of eggs. It is what we call quantitative assessment or intensity of infection by counting the eggs in a particular amount of stools. This is what we call KK, or Kato, K2, CATS, KATS, CATS test of detecting schistosomiasis. Okay, if we fail, then we can do sigmoidoscopy. Sigmoidoscopy, you can get the sigmoidoscopy polyps. You can take a polyp, look into the microscope for eggs, and then send it to histopathology for H&E staining, and you can see the granuloma entrapping the eggs within the middle. Okay, or you can even see the ulcers, see the polyps, and even if the stools are negative, sometimes if you take a snip from the rectal mucosa or sigmoid, then you can recover eggs. So that is as far as parasitology is concerned. There are two serological tests generally. You either detect antigen of a parasite or antibody, okay? And these are being detected according to what antigen comes out of the parasite. Okay, you can go directly to the antigen and say, well, there is an antigen of so-and-so, do a test and do relevance, correlation, and all the rest of it, and then you come out that the antigen is sensitive, or antibodies. As far as antibodies, these are the antibodies developed by the human against the antigen of the parasite. And this can be detected by ELISA, the immunofluorescence, okay, by gels tests and others. In schistosomiasis, antibodies are not useful. Antibodies are not useful. Why? Number one, it's cumbersome to do it. Number two, it doesn't tell if the infection is recent or old. Recent or old. Okay, so we rested recently into antigens. And there are two types of antigen, one cathodic, one anodic. CAA or CCA, which are glycoproteins that are being vomited by the worm. The worm will vomit this glycoprotein, and it goes in the circulation and can be detected. And it is a test of active infection. This is what is important. It is a test of active infection, which is cathodic or anodic. CC, circulating cathodic antigen, or CAA, which is circulating anodic antigen. And now these are being used to monitor treatment and monitor cure. Okay, My time is finished now. It's 60 minutes. Next time, I hope it will be half a lecture of what is remaining of schistosomiasis. But I would like you to Google Simmers periportal fibrosis. Simmers is an American scientist or American pathologist who described this clay pipe. He coined the name clay pipe, stem pipe, okay? And this is why periportal fibrosis, the American would like to call it Simmers periportal fibrosis, okay? I would like you to Google Simmers periportal fibrosis just on the mobile phone, and you'll find 3 papers from our group who describe the importance of ultrasound and the morbidity of schistosomiasis in the field. I think that was the first indication that the morbidity of schistosomiasis leading to periportal fibrosis may reach up to 16%. That was in that paper. For the first time, what is the morbidity of schistosomiasis? People used to count the eggs and say, well, this is the morbidity of schistosomiasis, but nobody has went to the end where they can say that it has affected so many patients by periportal fibrosis. This is what has been done. Secondly, it shows, the third paper, I think, it talks about reversibility of early periportal fibrosis, reversibility of early periportal fibrosis, okay? So these are 3 papers which are landmarks in schistosomiasis. Next lecture, we'll talk about, just to review about what we have said and talk about the drug. Because as I said, ultrasound and praziquantel are one of the major developments in the history of our knowledge to schistosomiasis. So with that, I would like to thank you very much for being with me, and I look forward to giving you the other part of schistosomiasis, because not only I'm very much attached to the knowledge of meaning I love working with schistosomiasis, teaching schistosomiasis. That's number 1. Number 2, it is very important among all tropical diseases, malaria and schistosomiasis. Thank you very much indeed. Bye-bye.
Very much, Professor.
Okay.